Welcome to the UW Carbone Cancer Center Community Luncheon. On behalf of UW Carbone Cancer Center, our advisory board, our many researchers and care providers, and especially the patients and families that are taken care of at the UW Carbone Cancer Center, I want to express my gratitude for the many ways you have partnered with us and support our shared mission of defeating cancer. Gathering together at this new time is our way of thanking you for your support and gives us an opportunity to interact with you and to give you an update and showcase some of the research and the stars that you help fund here at the UW Carbone Cancer Center. And we also are interested in your feedback as to whether this new time is more convenient or less convenient than some of the times when we've done it in the past. So please feel free to give your thoughts to us. I want to give a special thanks to the Emerging Leadership Board, the UW Carbone Advisory Board, and the Innovation Fund members for all their support. I also want to thank members of the Guardian Against Cancer Steering Committee who are joining us today, and also to our local and statewide community advisory boards as well that give us great input and advice in helping work and support all of you when it comes to our shared battle against cancer. We are especially excited today to announce a new partnership between the Cancer Center and the Wisconsin Alumni Research Foundation to form the UW Carbone Cancer Center Innovation Fund. Our initial goal is to raise $20 million in unrestricted gifts that will fund our shared mission of defeating cancer with multiple research, educational, and cancer care projects, which will enhance the promising new ideas and support all of the missions that we do together in responding to the cancer needs of our communities. This is also a chance for us to be more responsive to the changing world around us. As we all know, even with the pandemic and other issues, cancer is not slowing down and neither can we. So with your support, we are very helpful for this. Next slide. I'd like to take this opportunity to welcome our fundraising and development team, which we have here on the slide. We've had the opportunity to expand, to build upon our great team with new, strong and innovative staff. I look forward to many of you interacting with them and us working together to continue pursuing our shared mission in our fight against cancer. And you will meet many of these development team members in the coming months. Next slide. It's important for me to remember and take a moment to reflect on the 50th anniversary of the National Cancer Act, which is coming up this current month. In December of 1971, the National Cancer Act was signed. And I want to share the fact that the University of Wisconsin and the UW Carbone Cancer Center have had a pivotal role in that at the time and since. And on this slide, you can see President Nixon, but you also see two others. And these are two very impactful Wisconsinites, or as many of us would say, cheeseheads, that have been very involved in the fight against cancer. The first is Mary Woodward Lasker in the lower left. Mary Lasker was really one of the founding people in this act. She was born in Watertown, Wisconsin, and learned from her mother the importance of community service. She attended the University of Wisconsin before moving to attend college out east. But she is credited with, over her lifetime, of modernizing and developing the current American Cancer Society. And she was instrumental in achieving and pushing the politicians and the government regulators at the time to really focus more on cancer and cancer research. And she had a very famous saying, which is, if you think research is expensive, try disease. And that she really hammered this home, the importance of it. To the right is Dr. Harold Rush, who graduated, he's from Merrill, Wisconsin, and graduated from the University of Wisconsin Medical School in the 1930s. And Dr. Rush went on to create one of the country's first departments of oncology, which is still today, and developed the McArdle Laboratories for Cancer Research, which was one of the first funded basic cancer research centers in the world, and really led much of the development and the push for the development of comprehensive cancer centers as defined by the National Cancer Act. And with that, he led the development of the University of Wisconsin having one of the first comprehensive cancer centers in the country in 1973 as a result of his work. Next slide. The University of Wisconsin has been important for the National Cancer Act, as I mentioned, but we have been important in the war on cancer for more than 80 years. And this is evident in these slides that I'm about to show you, this slide and the next one. And it highlights the fact that researchers at the University of Wisconsin, and even now, have great global impact. And your support, your partnership with us is what has resulted in these events. And as you can see on the slide, whether it's the invention of Mohs surgery here by Dr. Frederick Mohs in the 1930s, whether it's the fact that currently we lead other cancer centers in the development of new cancer prevention agents, or the sheer number of all the research that goes on here, or the pediatric cancer dream team that we're a part of with 7 to 8 other institutions around the country leading that. Next slide. Or on this slide, as you can see, the Nobel Prize to Dr. Howard Temin, or the invention of 5FU, which was here in the late 50s, early 60s, or the development of tamoxifen, which is used worldwide for both breast cancer prevention and therapy. Again, that development here. So we're very proud of that. Next slide. What also is true is that the national impact of our cancer research continues to this day. And a recent example is shown on this slide. At the start of the pandemic, the NCI director was very concerned and wanted to sound the alarm that there was an alarming decrease in the way people were getting their breast cancer or colon cancer or any cancer screening, and that the numbers were decreasing dramatically because of the pandemic and the rightful concerns that people had over it. So Director Sharpless of the NCI based these concerns on breast cancer and colorectal cancer screening data and modeling. Next slide. And these data are shown here. Dr. Ozan Alagos of the CISNET data group around the country, which is led by our very own Dr. Amy Trentham-Dietz. And what this slide shows, and the main point I want to make, is that it shows that with the decreased screening rates, even in our state in Wisconsin, because the data is based on us and compiled by Dr. Trentham-Dietz and her team, and because they use us to model for the whole country, what it showed is that as breast cancer screening in the lighter blue went down, the numbers of people getting breast cancer and suffering from it and potentially dying from it would go up. And that's what this data shows. And the issue isn't so much the specific numbers, but to highlight the fact that our data and our shared work with you is impacting the whole country, but also to remind us that with the rightful concerns about the pandemic, and we understand that it's still incredibly important for you to continue with your health maintenance and the breast cancer, colorectal cancer, cervical cancer screening, all the different screening things, lung cancer screening as well. So please remember that as you go forward with this. So thank you for that. So at this time, I'd like to share a piece with you, a video piece that was produced this year by our team here at the Cancer Center. And it's highlighting the journey of one patient with advanced ovarian cancer to undergoing surgery to ringing the bell at the end of her treatment. And I think it beautifully highlights the important work that has continued at the UW Carbone Cancer Center despite the pandemic. And Emily, I heard that you may be in our audience this afternoon, so I want to thank you very much for allowing us to share your story with our audience.
I wish I could give you a hug.
I know. It is so good to see you.
Oh my gosh, it's great to see you.
Oh.
Yeah.
It's been a year since Emily has seen Dr. Ahmed Al-Niami in person.
Life other than COVID has kind of gone back to normal. And when I walk in the hospital walls here and see where I was a year ago, it hits you that that really did happen. March 17th, that's the day that I had to go through surgery, and basically you didn't know what was going to happen after surgery.
Around Christmas time of 2019, Emily was diagnosed with stage 4 ovarian cancer.
I thought I was going to die.
But after coming to the UW Carbone Cancer Center, her outlook changed.
After that meeting with Dr. Al-Niami, he just instilled so much hope in us that we felt so much better that there is going to be life after this. This isn't a death sentence.
Emily, who lives in Rockford, started chemotherapy at Swedish American Regional Cancer Center. A few months later, on March 17, 2020, she had surgery at the UW Carbone Cancer Center, just as the COVID pandemic hit.
With all the obstacles of COVID and all the times and the anxiety from the patients and their families, we discussed and said, well, you are first and the cancer is to be beaten.
COVID was kind of just not really in our minds that much. We knew what was happening in the world, but we just were so focused on what we needed to do here at the hospital and get through this surgery.
The surgery is complicated, of course. It was close to 8 hours. And we had to remove all the visible cancers. That includes multiple organs and multiple structures that needs to be removed. And she did beautifully. After that, she did very well with the recovery. She recovered without any complication. And then we continued with chemotherapy.
Emily went back to Swedish American Regional Cancer Center for 3 more chemotherapy treatments. 3 months later, there was no evidence of cancer disease.
I was trying to think what I would say to you, and the only thing I could say was thank you. You saved my life, so thank you.
This is a moment where all the hard work from her and her family, her friends, and the surgical team and the chemotherapy teams down in Swedish American hospitals came to fruition, and it came to the point where we have beaten this cancer.
I want to live my life, and I want to be positive, and I want to, do things, and I don't want to dwell on the fact that I had cancer. But at the same time, I want to be realistic and prepared for if it does come back, that I'm not blown away the way I was the first time. So there's a balance that I think a lot of cancer survivors have in the worry that it's always going to come back and the feeling of wanting to move forward.
Again, thank you to Emily and to Dr. Al-Niami and the UW Health providers involved in her care, and to our marketing and events and development teams for really putting this together and to show you this and to show the value and the support that your partnership with us on this creates for those from our community. So now I'd like to dive into our panel discussion, which we usually do, and featuring 2 remarkable researchers. Both of these researchers are helping us fulfill our mission of the rapid application of innovative cancer research and treatment across the state and world. And one of the things we want to focus on today is really the impact that partnering together we are having, not just locally, but in the state, the region, and the globe related to the cancer research that we do. So I'm about to introduce Dr. Megan Fitzpatrick and Dr. Kristen Malecki. Dr. Kristen Malecki is an associate professor in the Department of Population Health Sciences, and she's the director of the Survey of the Health of Wisconsin, which is overseeing survey implementation efforts and study development across the state. And she's been a leader in this area in developing and evaluating indicators of the environmental health risk assessment and policy and the effects that it has on chronic illness and especially on cancer. And that's developing models to examine the effects of the environment around us, whether it's air pollution, water pollution, and the social stresses that are afflicted upon all of us. Dr. Megan Fitzpatrick is an assistant professor in the Department of Pathology and Laboratory Medicine and is an expert in gynecologic pathology from her work both at Stanford University and here today. And she also has expertise both in research and the provision of cervical cancer screening programs, new implementation programs, new device development, and diagnostic test validation in low resource settings. So I want to welcome our 2 great researchers to our community luncheon today. Again, thank you, Dr. Malecki and Dr. Fitzpatrick, for your time. And as we have done in the past, we've put together questions that have been asked of the research and the impact that Dr. Malecki and Dr. Fitzpatrick have, and I'm going to put some of those questions that you've sent our way to each of them, and we're also open to other questions that you might have that you want to ask based on the answers. So I'm going to start with Dr. Malecki. Dr. Malecki, if you could describe for us the background a bit and the development that you put into the survey of the health of Wisconsin and kind of its value and how you are using it and intend to use it related to kind of assessing the risk of cancer throughout our community.
Yes, thanks, Dr. Bailey. Thank you so much for this opportunity to be here with all of you and to share what the Survey of the Health of Wisconsin program is. We call it SHOW. So it's not dancing on a stage. It's actually the survey of health across the entire state of Wisconsin. So the program was developed in 2008 with foundational funding from the Wisconsin Partnership Program. And it was really established without one specific research question in mind, but with the goals of monitoring the health of the population from in a unique kind of way. So we went to individuals' homes. We knocked on the general population's doors. So these weren't patients. These were just residents across the entire state, and we invited them to participate in the survey. We asked questions about individuals' health, and then we measured people's health. So at the time that the program was established, we had many different surveys out there, but what made SHOW unique is that we asked people about health, but we also measured health. So we measured height and weight and blood pressure, and we asked a lot of questions about people's lived experiences in Wisconsin and how that might shape health into the future. In addition to that, we also took biological samples. So individuals agreed to provide biological samples. And it's from all of those data, people describing their activities, their daily life, their context, how they feel in their communities, as well as the large biological samples that we can now put together a number of different pieces about early prevention and detection of cancer in the population. And so there's a lot that we can learn from this study about cancer prevention, but also more recently, as technology has evolved, how can we also use these data to help support new interventions or therapeutics for cancer treatment in the population?
Thank you.
Yeah.
Dr. Fitzpatrick, knowing your work and that you are well known as really being a global cancer expert and your research really encompasses the globe, can you describe how and why you've started and are doing the cancer screening research internationally that you do?
Yeah. So my interest in kind of global health research really began a long time ago. And I had done projects initially in child and maternal health. But as I embarked on some of my medical training, I had the opportunity to go do a rotation, actually, as a medical student in Guatemala. And there was one particular moment, one particular patient there that ended up really changing my focus of my career and my research. And she presented to the clinic and she had a young toddler with her. And she had her first pelvic exam. And at that time, we found a stage 4 of very advanced cervical cancer. And I'd already kind of known that I was interested in pathology at the time. So I had noticed that there was a microscope available at the clinic, but there was nobody there that was trained to be able to do pap smears. And, you know, I had really thought about cervical cancer sort of as a success story. And I had seen, you know, very few cases in the United States. But really, despite this success, which it is an astounding success of pap smears, limited access to screening really are persistent barriers to cervical cancer. And as you know, Dr. Bailey, if we catch cervical cancer early, we can really prevent a large portion of those cancers, and the survival can be up to 100%. But if we catch it late, the survival drops to below 20%. So every year worldwide, over 300,000 women still die of cervical cancer. But now over 85% of those deaths are in low and middle income countries and in underserved parts of high resource settings. So I chose this topic when I was selected for a global health research fellowship in Zimbabwe, in part because in Zimbabwe, the #1 cause of cancer-related death is cervical cancer. I'm very interested in virology and human papillomavirus. So the kind of research study that we were doing was centered around some of those questions. But we also were able to sort of deliver the study using community-based methods, and one of them is where the women could collect their own samples for cancer screening using usually a brush or a swab in the communities. And what was interesting is we didn't really find differences in human papillomavirus infect types between HIV positive and HIV negative women, which is what we were looking at in the research. But we did find that this method of screening was wildly popular in these areas, and that a lot of women participated that otherwise wouldn't have had access to screening at all. And what was interesting also is the intention on cervical cancer and cervical cancer screening at a place where we were working in a rural area that previously had no screening capacity at all. But the nurses and the community hospital got really interested and eventually trained. So we were able to establish and sustain the first ever cancer screening program there. It was initially supported in part by research funds, but now it's supported by the local government or the Zimbabwean government. And it really highlights the capacity for this research to improve other more sustainable programs in addition to kind of the research itself.
Thank you. Dr. Malecki, in your research, as I understand it, and others have said to me, that as you kind of go around the state and go into communities, you get a better sense of how illness, in this case cancer, might affect communities differently. Could you give some examples of communities or regions or even geographic areas in our communities where there's an excess burden of cancer and your thoughts of why that might be?
Yes, absolutely. So we have over the years gathered data on over 6,000 state residents to better understand cancer and cancer risks in populations. And what we know is that we see what we call disparities, so higher rates of cancer in some geographic regions. And we see that urban areas, lower income areas, where urban areas where there may be environmental exposures, but there might be other life stressors and other risk factors. We see higher rates of breast and lung and colon cancer. In our rural areas, we similarly see, but in different pockets of areas, we see increased risk of breast cancer and lung cancer facing. And there are many, many different potential reasons for that. And so the SHOW program is really working to better understand some of that by looking at private wells, looking at radon, for example. In rural Wisconsin, we know that radon is often undetected. Not many people know to test for radon, but we're asking about radon testing. We're also talking about private well testing. We knew that preventing exposures to some of these chemicals, people have to be aware. So we ask questions, and then we also provide information about how we can prevent some of those risk factors from happening.
Great, thank you. Thank you.
Welcome.
Dr. Fitzpatrick, as you were describing the work you're doing in Zimbabwe, and clearly that has a great impact on the communities there. Could you describe how that work might benefit or help us either better treat, prevent, or advise people in the United States or even in Wisconsin related to the work that you do in Africa?
Yeah, sure. So, when working in somewhere like Zimbabwe, the barriers to care are pretty dramatic. Often there's just no testing available. There's no laboratory, no pathologist, etc. But the fact is that even in the United States, cervical cancer disproportionately affects disadvantaged communities, despite the fact that some of these services are available. So we really need to rethink how we go about engaging women in screening, not just in Zimbabwe, but in other settings as well. And I think that my experience in Zimbabwe and other settings similar is really helping to inform some of the projects that we're doing in the state that are aimed at increasing awareness and screening and participation in underscreened women in Wisconsin. When I moved to Wisconsin in March of 2020, I started asking around about the barriers to cervical cancer screening here. And I was connected to the Milwaukee Consortium for Hmong Health. And this incredible consortium has been working to increase breast and cervical cancer screening in their community for years. But despite their increased screening rates for breast cancer, they expressed to me that there was still a relatively low participation in cervical cancer screening. We partnered first with them to help develop culturally appropriate educational materials about cervical cancer. But then I asked them if self-collect sampling might be something that they think would work in their community as well. And this is the topic of a study that we'll be starting in the spring in partnership with them to really just see if community health worker-led self-collect options would improve screening even in our own state.
Excellent, thank you. Dr. Malecki, as I understand it, a lot of your expertise in the research you do is trying to, again, better understand, as you described, what goes on in the environment around us, but also to even look at it at the personal level or even the cellular level of how the stress, affects us in many ways. So the question, I guess, given the current times for all of us, is how does the current pandemic, how are the ways that it, as kind of a stressor, could it be affecting our health or affecting our cancer risk, and your thoughts as to how or why that happened?
Yeah. So listening to Dr. Fitzpatrick talk, it's the commonalities from local to global and thinking about these pressing issues that we need to combat cancer. One of the biggest challenges we have across the whole population is establishing trust in the healthcare system, making people in both urban and rural communities feel like they can access the healthcare system. And we know from data from our own survey that during the pandemic, about 20% of people skipped a mammogram, and another 10 to 20 skipped some really important healthcare visits because of fear of coming into the healthcare system, maybe access to care. They already maybe had limited access to care, but then the pandemic has exacerbated some of that. So one of the concerns is that some of these disparities that we see, we know that early screening can influence that. We're going to continue to see. On more of a molecular cellular level, we know that chronic stress, we're 2 years into this pandemic, we know that our bodies can respond to and react to and recover on a cellular level from short-term stresses over time. We know that, and our systems are made up to do that. But when we have these stressors for longer periods of time, the balance of our repair mechanisms at our cellular levels within our genes, we can have increased inflammation, which can exacerbate many different processes underlying cancer and our immune system. We know that. But also it starts to have influence down the road on our just basic repair mechanisms related to cancer. So gene expression and other things with cancer. And so the show data can start to really understand that. We ask a lot of questions about stress and neighborhood stress and life experiences across the entire life course. And then we have this genetic information and we have biological sample data information to really start to understand what we call the weathering hypotheses, how these multiple stressors, not only in urban areas, but in rural areas of the state, can get under your skin to exacerbate disease risk, including cancer risk.
Let me follow up on that, Dr. Malecki, just to maybe on the functionally how you do it. My understanding is, can you describe that you literally physically, do you go into people's homes, you go into other things? I mean, just describe for us kind of literally how you do that, and how and when you're getting either blood samples or other things, or air samples or whatever, what have you.
Yeah, thanks. So we do. When the show program started, it was a random sample. So we took mailing addresses. We didn't know people's names. We didn't know anything. And we randomly selected these addresses. And then we sent field interviewers out across the entire state. And Wisconsin is amazing. It's very geographically diverse, but it's also people diverse. So when we send field interviewers out, we send residents, we hire people from local communities to help us with this work. And then we knock on individuals' doors, and then we ask them to participate in the survey. And that participation includes a in-home interview, and then an exam visit, and then some self-administered questionnaires. We also give people devices to measure their physical activity levels, and we do other things. We are planning for right now to do what we call longitudinal follow-up. So to go back and see people who have already participated in show and follow their health and life over time. Because of the pandemic, we are shifting a little bit. So we will be asking a lot of questions over the telephone, but these are individuals we've already had a relationship with. But then we will ask individuals to come to a location. We try to identify community sites, churches, hotels, other health departments that are trusted locations. We ask people to come to those locations, and that's where we do the blood draw and we do the physical measurements for the work that we do. But we try to make it as convenient as possible for anyone who's participating. And people can agree to participate in part or all of what we're doing with SHOW.
Thank you.
Mm-hmm.
Dr. Fitzpatrick, Dr. Malecki just kind of mentioned maybe the keyword convenience. Could you describe a little bit more what you've learned related to self-collection? You described a bit that you were doing that with specific populations, or that you'd, if I remember right, with your work in Zimbabwe. But if you could go into maybe a little detail with your expertise and knowledge, how does self-collection maybe improve or break down barriers or improve our ability to lessen the burden of cancer?
Yeah, so I mentioned it just sort of in brief, as if everybody would understand what I was talking about. So, but really, when I'm talking about self-collect sampling for cervical cancer screening, what that involves is a device, something like a brush or a swab, that a woman can use to collect the sample herself, and it actually is self-collect HPV testing is a part of cervical cancer screening in the Netherlands and Australia. In the Netherlands, actually, women can opt for self-collect if they refuse an in-office visit. But, it offers a few pretty big advantages for women. One is that it doesn't require a pelvic exam, at least initially, for screening. And the second is that it can be performed without the presence of a trained clinician, which is relevant not just in Zimbabwe, where that can be really hard to access, but that also means that it does have the potential one day to be done at home, sort of like colorectal cancer screening is moving that direction. So this means that you can also have nurses and community health workers involved in screening to administer, which takes a burden off the healthcare systems. And it also, I hypothesize, although I don't have proof, that it reduces some of the stigma and inconvenience factors of going to a doctor's office for this screening. And it really offers a unique opportunity to expand to hard to reach populations. In February, we're actually starting a clinical trial of a novel self-collect device. It was initially developed by a colleague at Stanford Biodesign, but we're really excited about the possibility to offer women this in both high and low resource settings alike, and to start the study right here in Wisconsin.
Thank you. Could maybe to follow up on a term you used, Dr. Fitzpatrick, could you describe maybe a little more detail when you say high resource versus low resource, what you mean by that, and maybe give examples?
Sure. Yeah. So low resource settings, are usually it's defined by gross domestic product or some sort of economic scale of economics of the country itself. But it more broadly, there are low resource areas, even in quote unquote rich countries. One example, I'm from New Mexico, and the Native American reservations there would be an example of a low resource setting in a quote unquote wealthy or high resource area as defined by GDP. So I use that term because I really feel like it encompasses a lot of the population that I focus on, which of course is global, but it's also in our backyards.
Thank you, Dr. Malecki. With your work around the state and the different communities, if you could just comment a little bit on your sense of, with your own work, how this idea of self-collection for screening can be of value relative to your work on access, stressors, et cetera, and how your data kind of moves you and how you feel that can be a value.
Yeah, it was really exciting to hear Dr. Fitzpatrick talk about the potential for a new screening tool that could be applied. So I see SHOW as a really important vehicle to better understand to reach out to residents across the entire state. So in a really easy study that was sort of bubbling up in the back of my head was, what if we use these resources and Dr. Fitzpatrick's tool to contact the show folks and say, how many of you, especially women in rural areas, we know through other work by Dr. Lisa Cadmus-Bertram that, there are many barriers to both accessing care and physical activity and other things that we know prevent cancer in more rural settings. So what if we reached out to them and said, what would it take for you to do self-screening? Is this even something you would want to do with that? We have this group of individuals who really represent Wisconsin residents, not necessarily patients, but people who live here and have lives here, to better understand, will these new screening tools be feasible, something that people would use? And if not, what are the barriers? And then that would allow Dr. Fitzpatrick to maybe modify how she implements it here versus another location. So having Wisconsin specific data would be really very beneficial in all of those contexts. And we've done that before with other things, but this would be an exciting opportunity to do that as well.
Thank you. Dr. Fitzpatrick, kind of following up further on that, it sounds like a great idea, and Dr. Malecki's kind of confirmed that sounds like a great idea, but what all goes into making a self-collection cancer screening system work? Or where is all the support that our community partners who are listening in, how their support really makes this happen, or the infrastructure needed to do it?
Yeah, I mean, it's a pretty big effort. And I mean, even it seems like a relatively sort of simple thing, because I mean, it does seem in some ways obvious, at least as a female who's had a pap smear. But on the other hand, you really do need sort of a big team, because you have, of course, the laboratory science side, the pathology side of making sure that every result that you're getting is accurate. And that you're really that it's safe. You have to make sure that of course the device itself is made appropriately, and so biodesign, but also device reconstruction, et cetera. All of that goes into it, and then the actual just the trial itself. So all the infrastructure that goes into running a clinical trial, where we ask people if they're interested and get them enrolled and follow up on all those results, takes a pretty large infrastructure and certainly the Cancer Center, help with IRBs and some of the FDA compliance issues and so on, and clinical trials, et cetera. Is sort of what's necessary in order to even think about doing something like this, and getting it to the FDA level.
Thank you. Some questions we're getting from the audience that I can follow up for Dr. Malecki. You've talked about and described the great work you're doing on really assessing what are the environmental factors and where they may vary in our region. What do you do with that data, and is it something where maybe you approach local or statewide policy or government makers to kind of either correct or impact that?
Yeah, thanks so much for that question. So on the research side, we really allow for asking fundamental questions. Are people in the population even being exposed to chemicals at levels that are known to cause cancer? So that's one way our data are used, both on a state level. We interact very closely with the Department of Health Services and the Department of Natural Resources in analyzing some of those data. Not all the data. It takes money. But we're working on several projects related to nitrates. Some of the other chemicals we're looking at right now are perfluorinated compounds. The State Lab of Hygiene came to us and said, perfluorinated compounds, maybe people have heard about PFAS. It was a chemical that was used as a flame retardant. So in many communities across the state where it's been spread widely, we're trying to see, are there community, it is in the drinking water, and are there communities at greater or lower risk of exposure? So that's one way we use the data in that context. And then we can give those data back to the regulatory and decision makers to really understand what they should be doing with those data. For one way the data have been used around protecting the population from environmental pollutants is that about 1/3 of the state of Wisconsin is on private wells. Normally, the private wells, Wisconsin historically has had really very good and clean groundwater compared to the rest of the nation. There are pockets of the state that have arsenic contamination, so we know that, and the health department really works with those well owners to test. but there are many private well owners that don't even know that the ownership over testing falls on them. So some of the actions we've taken is to follow up with the private well owners, one, to see are they testing, and we found out actually they're not. So now we're doing follow-up work with them to provide health educational materials to private well owners around what should be tested for, how often they should be testing, where resources are available at both the local and state level to help advance the testing, so that and what treatment options are available to them to reduce exposures if they are reliant on a private well. So those are some of the examples.
Great, thank you.
Mm-hmm.
Again, thank you to our community partners for the questions. Here's a follow-up question for Dr. Fitzpatrick. It basically centered around, is it a realistic goal to completely eradicate cervical cancer around the globe through whether screening, vaccination, other things? And if so, what might be other cancers that might be used, the cervical cancer as a model, or something that we could try and duplicate with other cancers?
Mm-hmm. Yeah, it's a fantastic question. And I think cervical cancer is, I mean, one of the reasons that I really enjoy studying cervical cancer is because I do actually feel like there is the possibility for eradication through a lot of methods. There's so many things available for cervical cancer. There's the HPV vaccine, screening, and to some extent early treatment for precancerous lesions. And the rhetoric, or the sort of the messaging from the WHO really has shifted in that direction towards how can we eliminate cervical cancer worldwide. And they've established some goals for HPV vaccinations and making those available worldwide in low resource settings as well. Is certainly moving towards that goal. And then obviously the screening and increasing access in all of the areas that really need it is really going to help. And then treating. So it's a little bit different age groups, and yes, it will take some time. But I do think that it is one of the big goals of the cervical cancer prevention community and those who study it is we should really be framing our thinking around, can we eliminate cervical cancer? And some other cancers, I mean, I think, of course, other HPV-related cancers, we're really hoping will follow on the tails of cervical cancer decreases. So these are other, genital cancers, anal, penile, vulvar, et cetera. But there's also oropharyngeal cancers, which a portion of those are HPV related as well. But I do think that it also offers hope to other screenable cancers and sort of the power of screening as well. And hopefully, other vaccines, although it's relatively unique that you get a vaccine that can protect against cancer. And that's a huge advantage.
Thank you. Probably our last question, or maybe one more, but let me ask of both of you, and I'll start with Dr. Malecki and then Dr. Fitzpatrick. If each of you could kind of describe both historically and currently how some of your research programs are funded or have been funded, and obviously we'd love to hear what you're doing with some of the cancer center funds that our community members have raised, where that helps out, and where their work is directly impacting kind of our cancer fight that you guys are wonderfully leading. So Dr. Malecki.
Sure. So the show program has historically been funded by the Wisconsin Partnership Program Foundation. We've added to that for some important initiatives like the Wisconsin Microbiome Initiative, which we added on to show. Some other initiatives, we've gotten some National Institute of Health funding for that. And recently, we're really excited to say that the Carbone Cancer Center has invested in the show program as a shared resource. And that's just a wonderful opportunity for us to really expand how our data and resources are being used across UW-Madison by multiple different investigators, and increasing the access of our data to investigators. For example, we do have an investigator who has a new screening diagnostic, and will be taking urine samples and testing that out. So it's a combination, and we will be continuing to look for additional funding to make all of the work happen, but we're really grateful to the Cancer Center for its support at this time.
Thank you. Dr. Fitzpatrick, you.
Yep. So a lot of the self-collect device work, we are pursuing extramural funds through the National Institutes for Health to fund the next phase of that work. But the Cancer Center has been really instrumental in some of the funding that I've received this year for looking at a different area of treatment, and actually precision treatment for cancers, and specifically immunotherapy. Which is a type of treatment for cancer that modulates the immune system to help basically attack the tumor. And what this really came to light, I started collaborating with Dr. Lambert in the McCardle laboratory, and he had discovered in a preclinical mouse model a very promising potential biomarker that could help us predict which patients would respond to immunotherapy. So with the support from the Cancer Center, we've been able to validate the biomarker in some of the head and neck cancer so far that we've looked at, and with additional funding from the head and neck SPORE here as well. So our multidisciplinary team, we're still looking at how to expand this, and so that we can really help clinicians better predict the response to therapy, and meaning that we can avoid some of the adverse effects from therapy as well, and prescribe it to people that we think are really going to benefit. So it's really special to be part of the discovery process and to implementation and to be supported.
Great. I'll make this the final question for each of you. Again, I'll start with Dr. Malecki. If you could just comment on what are the aspects of your work or your plans that give you the most excitement of the impact that your work has and will continue to have related to kind of the health of our state, the health of the globe, both cancer specific and maybe not necessarily cancer specific?
Yeah, I think what makes me really excited to be a scientist right now that has access to data from real people across the entire state is the ability to bridge sort of the cutting edge, novel, high impact, basic and clinical research that's happening and translate that into real world solutions for the population, but also to think about how we can now more than ever really start to look at these early indicators for disease so that we can prevent, individuals having to really suffer from disease once they get the disease, and really understanding who's the most vulnerable or susceptible to disease, and can we really use that science and information to have better treatments, better opportunities for prevention, and really improving quality of life for both cancer and non-cancer patients.
Thank you. Dr. Fitzpatrick, same to you.
She stole my answer. No, I mean, absolutely. What I think what makes studying cancer really interesting are the various areas that you can kind of intervene, and I think that the ability to study or to really kind of think about how to prevent this cancer from happening, and how to make treatments more accessible to people who really need it, and wherever they are, is really what drives me and my work is figuring out how I can best do that.
Thank you. For our community partners listening in and watching in, I want to let you know, and I have to be careful that I don't volunteer their time too freely, but both Dr. Malecki and Dr. Fitzpatrick are people, besides being great researchers and great speakers, are available to kind of describe and their work to you, and to even partner with you if you wanted to with your community groups or others, both in terms of them describing what they do, or if you were interested in your group supporting what they do, please let them or us know. But Dr. Malecki, Dr. Fitzpatrick, thank you again, not only for participating today, but for the great work that you do on behalf of our state, our region, and the globe. So again, thank you.
Thank you for this opportunity. Yeah.
So again, thank you to our community partners listening in, and we'll move on kind of to the last part of our luncheon time. And what I want to describe here, and as you've maybe gotten a sense from our panel, expert researchers, we wanted to focus on the fact that together we're trying to impact both by studying and impacting directly the cancer issues, not just in our local community, but in our region or state, but also globally. And I want to give you a follow-up on something that all of you have been instrumental in, and that is the Precision Medicine Molecular Tumor Board. And this is a group that really came about because of your support. And again, a credit to many, but specifically Dr. Mark Burkhart, Dr. Dusty Deming, and really some great staff who really have put a lot of time and effort into it. And your support developed what we call the Precision Medicine Molecular Tumor Board. And what it is their expertise and of others here at the Carbone Cancer Center and around the state were put together and provided for free to any cancer patient or cancer physician on behalf of their patient around the state, and would provide basically a free consultation helping interpret what is called personalized medicine data, which is looking at specific mutations in the cancer cells of a person with cancer, and looking at the potential of very specifically designing the treatment around that, rather than all breast cancer patients being treated one way and all colon cancer patients another. It's looking at their specific mutations and giving the best care for that built around the mutation. Because there more and more of our anti-cancer medications are very specific, or what we call targeted, to a specific cancer-causing mutation. And to give you an example of it, some work from Dr. Deming and his research team noticed in an elderly gentleman from the northern part of the state with colon cancer, who was interested in what there might be available for treatment, but he did not want to get regular chemotherapy like 5-FU, as you saw in the beginning, invented here at the University of Wisconsin. And what they found with their work was that this particular person had a very specific mutation, more commonly known in breast cancer, and there was a specific targeted type of immune therapy for that. And they tried this based on the recommendations of the Molecular Tumor Board, and it worked exceedingly well for this individual. And that data was then shared around the globe and is now really a standard of care for certain elderly patients with colon cancer. If they have that mutation, the recommendation is to give them this more commonly known breast cancer drug for people with advanced colon cancer. And it's really made a great impact, not just in our state, thanks to all of your help, but really around the United States and around the globe. What this slide shows is that what started with just a handful of patients about 5 or 6 years ago has literally grown to where this is now helping and has helped more than 5,000 cancer patients around the state. And in fact, again, with your support and help, it is now funded through the state partially as well. So again, that's really an example of all of us working together to benefit the communities around us. And again, with great support and great involvement from other cancer physicians around the state, not just here at the Carbone Cancer Center. So that is stuff that you've done. And on the slide, we want to keep growing this, and we are, to further impact both our hematologic cancer patients, to provide greater impact for pediatric cancer patients, and to continue to expand it into even the further reaches of the state. So that's something that again, you've been a big part of, and we really appreciate what you've done over the years with that. Next slide. And what I wanted to close with is, again, to give you not only how your support is impacting our state, but also how your support is impacting the country as a whole. And what this slide shows is a number of places around the United States, and we don't show some of the spots as much in Canada, but where your support has allowed us to take our research and not only apply it to our patients in our region of Wisconsin, Northern Illinois, Minnesota, Iowa, but to expand it and help patients around the United States. And what this diagram shows, where you see the icons of people, are other bigger cancer centers all over the United States that are participating in studies run by us whether that's cancer prevention studies or cancer therapy studies, that they are benefiting from the research occurring here and the support and the partnering that you've allowed us to do with that. So again, your impact and our gratitude for that impact isn't just limited to our state, it really is across the country and indeed, as you heard from Dr. Fitzpatrick, across the globe. So again, we're incredibly appreciative of all that you do with that. So again, on behalf of all of us at the UW Carbone Cancer Center, the researchers, the providers, and especially the patients and the families of our patients, we can't thank you enough for your willingness to get involved, your willingness to partner with us, to give of your hard-earned resources, and most importantly, your time. Nothing gives us more inspiration and supports patients and their families more than knowing that there are so many out there that are pulling and working with us to improve and to get rid of the struggles that we all have with cancer. So again, your involvement is incredibly important to us at so many levels. So thank you, and please again give us feedback about the parts of our luncheon that you liked or things that you'd like to hear more about, whether it's topics or the ways we do it. But again, on behalf of all of us, we are so grateful to you and your time and resources and support of our shared mission against cancer. So with that, we'll close a little bit early. But again, thank you everyone for your time, and I look forward to seeing all of you in the near future. Thank you.